you for coming. And I will be going through our standard patient preparation before every coronary CT. And it's like a quality assurance process that needs to start once we meet the patient. So the patient preparation is actually a quality lever. It's not just a checklist. We have to make sure that we foresee and mitigate all the artifacts and produce a quality exam so it's going to be interpretable and have very high positive predictive and negative predictive values. So we need to control, or there are 4 domains that we need to talk about. The cardiac motion for the motion artifacts, and it's really controlled by a lot of factors of patients' breathing, heart rate. So we need to control the heart rate variability, beat to beat variability, even if the heart rate is below 70, which is our target. And we need to ensure that the coronary caliber is at its widest, and we need to use pharmacology for that. Also, the vascular enhancement is our key, so we need to make sure that we acquire a good IV access. So the non-pharmacological preparation usually start by talking to the patient, comfort him, telling him what is going to be the exam like, what it's like to stay on the motionless and have to hold your breath. So the patient has to go like voiding, and all of this are standard, and our great technologists take care of everything once the patient is in the suite. So the patient has to have a very good position, arms above the head to avoid beam hardening or any photon starvation artifacts that can arise from arms next to our target, which is the heart. And we should coach him how to do breathe holding, which is mid deep inspiratory hold, no Valsalva, because Valsalva increases the thoracic pressure and can interfere with our contrast. And then the patient should know that the gantry has a noise and it moves. So sometimes the patient may feel a little bit of an anxiety or panic attack, although he has been coached, just because of the sudden motion of our table inside the CT scanner. So we're going to start with our heart rate control and heart rate variability. Our first line is a beta blocker, metoprolol per oral. We can start on a lot of our protocols now. We tell the patient when to take it the day before or the day of the exam. If the patient heart rate is not controlled or it's an inpatient, 5 milligram IV on the table can be done, and it can be repeated every 5 minutes to a max of 20. And there are patients that we cannot do the beta blockade, which is like severe bronchospasm, second degree or third degree heart block, which is usually bradycardic. And the ivabradine is a second line, and it's a funny channel blocker, and it works only on sinus rhythm. The patients who are not on sinus rhythm, like atrial fibrillation, it will not be effective. And we give the ivabradine 5 milligrams the night before, and 5 milligrams the day of the exam. There is some non-reformability IV of ivabradine, but the commercially available is the oral. Again, we should not give it in patients with atrial fibrillation. It doesn't work. And it has some other pharmacological side effects, although if it's given like the CYP34 inhibitor, it's recognized as strong side effect. The last resort is adultizing and duratamab. They are a form of beta blockers, suitable agents. They are a calcium channel blocker. They have a profound hypotensive effect, but sometimes they are given to patients who have bronchospasm. And this is why it shares some of the side effects with beta blockade, with decompensated heart failure, profound hypertension, but it doesn't have the bronchospasm effect of the beta blockade, and they are quite potent. Then the nitroglycerin, that we have to give nitroglycerin. It's non-negotiable, because most of the studies said that all coronaries have increased luminal patency by 21% on given the nitroglycerin. So in patients who are not primed with nitroglycerin, we expect that we will undersize the coronary artery and may call false stenosis. So nitroglycerin is given 0.4 to 0.8, has to be within 1 to 5 minutes before that actual exam acquisition. We need to just make sure that the patient is not hypertensive and he will tolerate the nitroglycerin. The only key factor that we need to talk about with dealing with nitroglycerin, because some patients may be allergic to it, but the patient who never had nitroglycerin before, we need to ask about phosphodiesterase inhibitors, which are like the sildenafil and the tadalafil. And when was the last time? And we need to ask it explicitly, because a lot of patients do not get the association and may not disclose that they take this medication, especially if they take it sporadically. For the venous access, we need to make sure that we have a high quality and standard access protocol. It has to be 18 gauge, and the factor why 16 to 18 gauge can tolerate the contrast injection rate. ensure a good opacification of the coronaries, we have to inject with a rate greater than 5 milliliter per second. And 16 to 18 gauge can achieve that. Anything below 18 gauge, like 20 gauge, our ceiling is around 4 milliliters per second contrast injection rate, which will decrease the contrast amount and hence enhancement of the coronaries. It's preferably in the right arm because the left pathway can sometimes cause a streak artifact if the contrast column is prolonged. And sometimes if we can achieve contrast enhancement if the patient is smaller in size or in weight with 4 milliliter injection rate, at 20 gauge can work. Avoid hand and breast. And we have to test saline test to avoid extravasation because it's a repeat and it takes a lot of time and the patient becomes anxious and his heart rate becomes uncontrolled. And also high risk history, we should not put IVs in dangerous situations like an arm with chemotherapy or a mastectomy with a history of mastectomy on that side, prior extravasation, and not all central venous lines can work. We have to verify that they are power injectable. And we have an escalation ladder to go through. Like it's peripheral. If it's not working, we need to get an ultrasound guided assistance to put an IV within the tracheal the basilic veins. It says existing central lines can work only if they are power injectable. So that can be verified by the technologist and the team. And we can place a central line in select cases. Sometimes we can tell them temporarily we're going to have to put a central line to get that exam, and then the team can decide whether to keep it or not. And so this is in summary what I have to say. First interest for successful cardiac CT, we have to pre-scan script. We have to have standard talk, what we're going to tell the patient and how we're going to prime him on the CT scanner. Then we have to test the ID after we fill it, and then we will calculate the bolus timing and we rehearse it with the patient and confirm the medication allergies. We give them the beta blocker, control the heart rate, give them the nitroglycerin, and document the prep. Document the prep is very important. And this is an algorithm, what to do with your patients showed up. If the sinus heart rate less than 60, you can go ahead, put the nitroglycerin, and proceed to the CCTA. If the heart rate between 60 to 80, you can either give a 50 milligram oral and wait, or you can give an IV on the scanner, and then the nitroglycerin and apply. If the heart rate is greater than 80, or there is a calcium, or like use of calcium channel blocker, you can add ivabradine as an add-on therapy. Sometimes that can make the heart rate go down to 70, 60. Atrial fibrillation, we are really tied. We have to use mainly verapamil or beta blockers, and that will control the heart rate. Although there will be some form of B2B variability, and then we can adjust the scanner to acquire a longer time of the cardiac cycle, and we have to do something called the selection of the phases on the scanner, which is easy to be done, and we can do. And that is